Good afternoon, all professor and colleagues here. My name is Nguyen Minh Dung from Thoracic Surgery Department, Yonsei University. Okay, now let's imagine that one day there a patient with the end-stage lung disease come to your hospital. They need the lung transplantation, but suffer from the heat, heparin-induced thrombocytopenia. How can you have the patient undergo the lung transplantation and recover well? I think it's kind of complicated scenario that you have to face up. And today I'll give you one solution. A 62 male patient come to our hospital for lung transplantation evaluation. He suffered from pulmonary fibrosis, which was confirmed by biopsy. And one remarkable thing in his medical history that the patient suffered 4 times of lateral deaths and 1 time of exploratory thoracotomy 5 years ago because of the recurrent pneumothorax. Here is the lab result. You can see that the patient got the pulmonary artery hypertension and his pulmonary function tests were very bad. This is the reason why the patient is an appropriate candidate for lung transplantation. Okay, 1 month prior to the lung transplantation, he was admitted because of his dyspnea became worse and worse. At that time, we need to give him some medication. So the PICC inserted at that time. To keep the catheter patency, we use some heparin flush. And just 10 days from the first dose exposure to the heparin, his platelet count dropped by more than 50%. At that moment, we thought maybe the patient suffered from the heat, especially his 40 score around 6. 2 points for drop more than 50%, 2 points for it happened within 10 days, and 2 points for no other causes, and 0 point for non-thrombosis detected. So we did another test like the anti-platelet antibody test, like abdominal ultrasound, like liver function test, and it's all normal. So we did the anti-BF4 antibody test and it's positive. So from that moment, we stopped using heparin, and 10 days later, it back to the normal range. But his dyspnea became worse and worse. We need to do something for him, and when the lung donor available, yeah, he is the chosen one. But now, what should we do? What should we do with his? At first, we plan to use argotraban as an alternative therapy, but unfortunately, there were no argotraban available at that time. And another reason is that you can see the patient had a high risk of bleeding because of he suffered from a lot of multiple thoracic surgical procedure before. So we try to find another way, and here another way is the last mile exchange. Here our whole procedure. First, we did the last mile exchange directly before the surgery. Then we do the lung transplantation with our standard technique. It lasted less than 5 hours, and right after the surgery, we can win up from VA ECMO to VV ECMO and win up ECMO within a day after the surgery. As you can see, we used just only 500 units of heparin during the surgery at the time of cannulation. But after the surgery, there is another drop in platelet count, but with only 6 units of heparin concentrate transfusion, it back to normal range, and it kept that stable for the next 2 weeks. After 3 weeks from the surgery, the patient can discharge from the hospital, and 1 year follow-up, as you can see here, the platelet number kept in the normal range. And here is the image of the lung before and after the surgery. You can see the big change for the patient. And until now, the patient is still in the good condition. I know that, and you know that, heparin is essential, especially in cardiothoracic vascular surgery. We have to use heparin in a lot of procedure, especially the patient, on patient with lung transplantation. We need heparin for like preventing thrombosis or running ECMO. So the heat is the thing that we had to face up. sooner or later. So today I want to give you a weapon to save patients from death. That is like the last mile change with the daily count monitoring and try to use the small dose of heparin. 감사합니다. Thank you so much.